Hello, everybody. Welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Issam Turk, a gastroenterologist at Monument Health. You've got to be one of the newest members at Monument, I think, Dr. Turk.
Yeah, I joined. How you doing, Mark?
How are you?
I'm happy to be here.
Great.
So, I joined in January, right after the new year.
Oh, all right. So you're just fresh. Getting used to everything.
Yeah,
you are.
New to the area, new to the system, and still getting settled and pretty much settled in now.
Sure.
But I'm new to the area, new to the monument health, and so far so good. I mean, I love it here.
Well, what brought you into this field, doctor? Why gastroenterology?
So I'll be honest with you. I mean, so to get into GI, you have to do internal medicine residency.
Okay.
So I did 3 years of internal medicine residency, and after that, you could either go into primary care or just do inpatient like hospitalist medicine, or you could subspecialize. So during my internal medicine residency, you do elective rotations, and the first one I did was GI. And I really did not know I was interested, and I just did it, and I ended up loving it. I mean, it was a month, and I thought it was fascinating because there's procedures, there's the clinical aspect of it, and again, the field of GI is vast, and it goes again. People think when they think GI, they think we're just doing colonoscopies and just dealing with butts all day. It's much more than that. I mean, again, it's from the mouth all the way down to the rectum, and your whole GI tract it's fascinating. And again, the liver, it's one of the most fascinating organs there are, and then the pancreas, and then you have the cancers, and that's unfortunate part of any really organ system. And then you have your IBDs, Crohn's disease, ulcerative colitis, and you have your GERD and your IBS. And again, there's the procedural aspect, which we do a lot of procedures, and I enjoy that. So I like the fact that I could see patients in the outpatient setting, in an inpatient setting, and then do procedures. So it just kind of keeps. It's very exciting.
Yeah,
that's why I enjoy it. Honestly,
I mean, it seems like it just by your explanation there. That it is. I mean, it's just there's so much that can go wrong with us. That's the thing.
100%. I mean, we're always eating and we're pooping, and so much can go wrong with both, right?
Right, all the time.
Again, things can go wrong with eating, where food can get stuck.
Sure.
And we deal with that, and then things can go wrong with pooping.
Right.
Whether you're constipated or diarrhea or having bleeding down there. So it's a very important field, and it's important once you start experiencing the pathologies and diseases related to it. And I love it. Honestly, I can't see myself doing anything else. So I applied, and right now it's actually the most competitive. I was just on stage the other day. It's the most competitive field to get into through internal medicine out of all the different subspecialties, because I feel like it's just the lifestyle of it, and then the field itself is so interesting. And right now, over the past 5 years, it's been the hardest field to get into out of internal medicine.
Wow.
So I feel like I'm very fortunate to have matched into GI, and I've been practicing gastroenterologist for about 4 years now.
Okay.
And I love it.
Well, I'm personally super excited for this topic today because this is something I've been suffering with for about 20 years right now. And I have heard...
And you're young.
Yeah,
I mean,
I think so.
Yeah.
You are
young.
I still feel that
you look
way.
Young.
Right? Thank you.
You're beautiful, vibrant, amazing beard.
That's the first time I've been complimented.
Yes,
Thank you, Dr. Turk.
Except for your diverticular disease.
Right.
I don't like that about you. But other than that, I mean,
great.
Yeah.
Well, we want to talk about diverticulosis, diverticulitis.
Yes.
Right? One becomes the other, if I understand correct.
Yep,
all right.
Yep.
So let's just start with the basics then, Doctor. What exactly is diverticulitis?
Sure. So again, like you mentioned, and before we started talking, you said you've been dealing with diverticulitis for 20 years. And that right there is a mistake, because if you've been dealing with diverticulitis for 20 years, you'd be dead right now, right? Because diverticulitis, as we know, anything in medicine that ends in itis means inflammation or infection, right? Inflammation usually. So diverticulitis is an actual disease, is a problem. It's something that's acute. Diverticulosis is the condition where you basically have pockets or outpouchings that form within the colon, okay? So you can get diverticulosis anywhere in the GI tract. You can get it in the esophagus, which is rare. I mean, Zenker's diverticulum, which is outpouching in the esophagus. You could get diverticulosis in the small bowel, which is extremely rare, but most commonly is diverticulosis of the colon, the large bowel, right? So this is what we see all the time. It's very common. I mean, at age 40, it's about 20% prevalent. And then once you hit 60, it's about 60% in 60-year-olds. You hit 80, it's 75 to 80%. So it's very common, okay? Having diverticulosis, the actual condition where there's pockets in the colon. And it happens because we don't know exactly why it happens. There are theories. I think constipation. We definitely see it as you get older. There's some genetic predisposition, especially in someone like you who's dealing with it at a young age. But we don't know exactly why it happens or who's predisposed to getting diverticulosis compared to who's not. But we know that there's a genetic predisposition. And then there are theories, okay? And then we'll talk about risk factors because diverticulosis in and of itself is not a problem, but complications of diverticulosis is what's an issue, right? Such as diverticulitis, which is infection or inflammation of the actual pocket, or diverticular bleeding, which is another problem. And it's important because it's actually the most common cause of GI bleeding. So when someone has bleeding from their GI tract, if they're vomiting blood, that's usually the most common cause is an ulcer in the stomach. But having a lower GI bleed, the most common cause of lower GI bleed is actually diverticular bleeding. And they bleed like hell. I mean, I'm talking, as opposed to like hemorrhoidal bleeding when they're bleeding from their hemorrhoids. Sometimes it's a little bit of blood mixed around the stool or when they wipe. Diverticular bleeding, it's like you just opened like a faucet and it's just gushing out. And sometimes the patients will pass out. And if someone is on blood thinners, then they bleed big time, okay? So in terms of lower GI bleeding, it's the most common cause of lower GI bleeding is diverticular bleeding. Now, the good news is when that happens, 80% of the time, it stops on its own, but sometimes it doesn't. And when it doesn't, it's a big problem because the patient can crash. I mean, they bleed a lot. And they require blood transfusion sometimes. And, there are different things that we could do to stop it and control it. But like I said, 80% of the time, as long as they're not coagulopathic or they're not on a blood thinner, it stops on its own 80% of the time. And other times it doesn't. There's different things that we could do to stop it, whether endoscopically we scope them or we rely on our friends from interventional radiologists. And I'm not going to get into all that. It's like fancy different procedures. But again, so diverticulosis is the condition where there's pockets that form in the colon, weakening of the wall. In this part of the world, it's common in the left part of the colon. So your colon goes from your rectum, sigmoid colon descending, that's the left part of the colon. And then in the middle, you go transverse colon. And then the right part of the colon is the ascending colon to cecum, okay? So in this part of the world, it's common in the left side of the colon. Sigmoid.
Is it common in other places, in other parts of the world?
So in Asia, it's right-sided. It's very interesting.
Really?
The Asians, they have it on the right side. Us Americans, we have it on the left side. So in this part of the world, it's common, again, in the sigmoid colon descending. And this is what I see. So how do you diagnose it? So if you have diverticulitis, you would know because it's an acute presentation. You're having pain, you're having fever sometimes. A lot of times constipation because the lumen, the inside of the colon, becomes kind of narrow from the inflammation. But the pain usually, if it's in the sigmoid colon, which is the most common site, pain is in the left lower quadrant, and it could be excruciating. It's almost like appendicitis.
That is one thing I can speak to. I have had that pain, and it feels like someone is just squeezing you on the inside. And it's debilitating almost. And like I said, like fever, that can all accompany that.
Fever, chills. Again, sometimes you can get septic from it. That's when the infection is really bad. But, again, with diverticulitis, when you're having the infection or inflammation of the pocket, that also could be, there's levels to it, right? It could be complicated or uncomplicated. Uncomplicated means the pocket itself is inflamed and, you're having the pain. Blood work will show like your white count's elevated, you might have a fever, but there's no abscess with pocket of pus or perforation, okay? Now, complicated, on the other hand, could be a disaster, right? As you could develop an abscess, and depending on the size of the abscess, it could be managed just with antibiotics, bowel rest, which is how you manage diverticulitis in general, or if it's larger enough, usually 2.5 centimeters or bigger, then it needs to be drained. Or if it's perforated, that's when the pocket ruptures. that's very bad. I mean, that's when you get into trouble. You get peritonitis, the cavity around it becomes infected, stool leaks where it shouldn't, and you end up needing surgery. And then the mortality rate is very high in that situation because that's no joke. I mean, so sometimes we see microperforation, which means there's a little bit of like oozing of air, as opposed to frank perforation. With frank perforation is basically it's ruptured and the abdomen becomes distended. The patient is very sick, their blood pressure tanks, and they need like emergent surgery. So diverticulitis can be uncomplicated, which I'm assuming is what you've experienced.
Yes.
And that's managed with bowel rest. So put you on liquids for a few days, antibiotics. In the outpatient setting, you could treat it with oral antibiotics, 7 to 10 days. That usually takes care of it. And then sometimes if it's really bad, then you end up being hospitalized for it. You need IV antibiotics. And once your white count's improving, you're feeling better, they transition you to oral antibiotics. Now, the important thing is if someone gets diverticulitis, unless they've had a colonoscopy within the year, then 6 to 8 weeks after their attack, they need a colonoscopy. You never do colonoscopy when someone is having an acute attack because think about it. You have the pocket, it's inflamed, and the lumen becomes narrow. If you try to scope someone while they're having an acute inflammation, an acute attack, you could perforate them.
Right.
And that's actually one of the major contraindications to doing a colonoscopy on someone is someone who's having acute diverticulitis. You do not scope someone ever who has acute diverticulitis. So you wait 6 to 8 weeks because 6 to 8 weeks, that's enough time where the flare has kind of gone away and it's subsided and the patient's better, and then you scope them. The reason you scope them is to confirm that this is purely diverticular disease that's become infected rather than a big polyp or a malignancy, cancer. Because before the era of screening, because now we have screening, which I know Dr. Zakaria gave a talk the other day about, 45 is the new 50, etc.
Right.
Before the era of screening, this is how a lot of patients presented with cancer, is they would have diverticulitis and then come to find out they have a mass there that's blocking the pocket or a big polyp, and then this is how they get diagnosed. So that's why if someone hasn't had a colonoscopy within a year, then you scope them after 2 months, 6 to 8 weeks, to make sure that this is diverticular disease that's gotten, infected or gotten complicated versus a big polyp or a cancer that's brewing, okay? If they've had a colonoscopy within a year, then you make sure that it's a high-quality colonoscopy, review it. If they've already known to have diverticulosis on the colonoscopy, then you don't need to rescope them. And then you do things to prevent it. And we'll talk about that.
Yeah.
We'll talk about the risk factors. We'll talk about things to prevent it. And because we already kind of touched base on the management. The management, like I said, bowel rest, antibiotics. If it's complicated, then they might need surgery. If there's an abscess, they might need drainage of the abscess. But then the important thing today is to talk about risk factors and things to do to prevent diverticulosis from getting itis.
Let's start with
exactly.
there. Absolutely. Let's do that. Let's talk about the risk factors and what you can do, okay?
Yes. So I'll happily talk about that. So first of all, there's a myth, okay? Back in the day, they used to say, if you have diverticular disease or diverticulosis, you need to, I'm sure you've heard this, avoid popcorn, seeds, and nuts. You've heard that, right?
Yep.
Exactly.
I haven't eaten a strawberry in 20 years.
Okay, well, guess what? Go ahead. Today, you can go crazy on the strawberries.
Right.
Because
Very good.
a study came out in 2008 by JAMA, and it showed that there's really no linkage. That's an old myth. And it's a lot of, not, hate on the old school doc, but it's something that a lot of the old school docs will say. It's like, avoid popcorn, seeds, and nuts. I mean, personally, I would love to tell people to avoid popcorn because I hate popcorn. Because my biggest pet peeve is when I go to the movie theater and someone's next to me eating popcorn, starts chewing.
Yes, I totally agree.
That drives me nuts. So if anything, I would love to go out there and say, everyone just ban popcorn and stop it, because purely I can't stand when someone's next to me in the theater eating popcorn. But no, really, there's no linkage, okay? With that being said, I tell patients in moderation, right? You want to have popcorn or have seeds, go ahead, have it. Just don't overdo it. But the study was legit. In 2008, showed that there is no correlation. There's no linkage. Because, I mean, it's not like when you're eating popcorn, seeds, and nuts, by the time it makes its way to your colon, it's staying in its exact state and it's going into the pocket. Because how do you get diverticulitis? Hardened stool will get into the pocket and it'll get impacted. And then that's how it gets infected, okay?
Okay.
Same with diverticular bleeding. The wall is becoming thin, and then a vessel will rupture, and then they bleed, right? So the idea is you don't want stool to kind of be hard and get into those pockets. So, and then with that being said, things to prevent that from happening. So popcorn, seeds, and nuts, it's fine. You can have it, truly, in moderation, okay? Just like water, good for you.
Sure.
Drink
Moderation.
10 gallons a day, you die, right?
Right.
So again, just like anything, you can have it in moderation. So my patients who do have that, who've been told, I tell them, listen, you can have it. It's not a big deal. Now, big risk factor, and it's something that I actually see all the time, especially in young patients like yourself, young, beautiful, vibrant patients
thank
like
you
yourself.
very much.
Yes.
I'll just let you go
amazing
on.
Beard, amazing beard.
Yes, thank
Anyways,
you.
so one of the biggest things is NSAID use, okay? NSAIDs, non-steroidal anti-inflammatory drugs, like ibuprofen, like Motrin, Aleve, naproxen, Celebrex, full-dose aspirin, not baby aspirin. Those medications, we know that they're linked to a lot of issues in the GI tract. In the upper GI tract, ulcers, right? I see it all the time. Patients pop in Motrin like candy. They come in with bleeding ulcers. But also, I've seen patients who are young who keep getting recurrent diverticulitis, and then I find out they're just taking NSAIDs all the time. And that is one of the big risk factors is NSAID use. So someone who has diverticulosis or recurrent diverticulitis, you want to make sure that they're not taking NSAIDs. Now, once in a while you want to take it, that's fine, but chronic NSAID use in general should be avoided. It has negative side effects on the kidneys. You can get NSAID-induced nephropathy. On the GI tract, we know so many issues, and I'm not going to get into it, but for the sake of the talk, definitely diverticular disease complications, there is a correlation with NSAID use, big time. So that's one thing. Another thing is obesity, okay? There is a linkage between obesity and complications of diverticular disease. So stay fit, stay active, don't be obese.
Right.
You're not obese.
Thank you.
I'm talking to you
Yes.
in general.
Yes.
Another thing is staying hydrated. So hydration is key. You want to be hydrated and avoid dehydration. And then one of the biggest ones is fiber, okay? So high fiber diet or psyllium fiber supplementation like Metamucil, Benefiber, because and that is not to be confused with like Miralax. Whenever I tell patients, okay, you need to take Metamucil, like, oh, I don't want to have diarrhea. No. I'm not putting you on a laxative.
Right.
This is psyllium fiber. What that's going to do is going to add bulk to your stool, so that way your stool is bulky and it could glide over those pockets, so it doesn't get so basically. High fiber diet, psyllium fiber, supplementation, like psyllium husk, staying hydrated, avoiding NSAIDs, and then avoiding smoking. Smoking is another. Smoking is a risk factor for everything, right?
For
but
almost
again,
every problem.
It also is a risk factor for diverticular disease, right? So in someone who has diverticulosis, so when I scope them, for example, and I find it incidentally, so again, diverticulosis, you find incidentally, right? Because you don't feel it. Having the condition itself is not a big deal, but then when you start having issues like diverticulitis or bleeding, then you know, right? So most of the time, that diverticulosis is diagnosed incidentally, which means you have a CAT scan done, and then it shows up on the CAT scan. Or I do colonoscopy for screening purposes, and I see diverticulosis.
Right.
So then you know that you need to kind of be aware that you have this condition, and the goal is to prevent it from becoming complicated or having like I said, diverticulitis or diverticular bleeding. So the way you find out you have diverticulosis is by chance, by chance, which is during a routine colonoscopy or screening colonoscopy, or if you have a CAT scan done for whatever reason, right? You find out you have diverticulitis because you would know you're having pain, and pain is severe enough where you end up in the ER, they do a CAT scan, it shows that you have diverticulitis on the CAT scan, and then boom.
Right.
So, just like how diverticulitis can be complicated or uncomplicated, diverticulosis could be mild, I see a few pockets and I mention it, or it could be the whole colon is diverticulosed. It literally looks like a war zone in there, where it's just like pockets and craters everywhere. So if someone has extensive diverticulosis and they've never had diverticulitis, I'm like, wow, you're lucky, but do this and this and this to make sure that you don't end up in trouble, right? If someone's got, like yourself, recurrent diverticulitis, the first thing I do is I find out what their lifestyle is like. Are they taking a lot of NSAIDs? Boom. That's usually what it is, right? And then if they are, then they stop it. Are they staying hydrated? Are they doing are they making sure their fiber intake is adequate? Are they supplementing? And are they avoiding smoking? Now, sometimes there's a patient that is doing all the right things, but they keep getting attacks. Now, in those situations, that's when surgery comes in, okay?
Right.
So the rule is, if you've had more than 2 attacks within a year, within the same site, right? Like in the sigmoid colon, for example, which is the most common site. because that's where like there's increased pressure and the colon does like a sharp turn. There's angulations. So if the rule is if you've had more than 2 attacks that are confirmed, okay, then that warrants a conversation
Right.
with surgery to talk about the risks versus benefits of surgery. So if a patient of mine or a C patient, they've had more than 2 attacks in 1 year, especially if they're young, then I refer them to colorectal surgery or general surgery, and they talk about doing what we call Hartmann procedure or surgical excision of that part, because that part of the colon becomes kind of floppy and becomes kind of predisposed and prone to having multiple, especially if they're doing all the right things and they're still getting diverticulitis. I don't want to wait till their next attack is a
Right.
complicated one where they have an abscess or they have, God forbid, a perforation. Then guess what? They need a surgery whether they like it or not. And that surgery is going to be in an acute setting where basically the mortality rate is high and complication risk is high. And they're definitely going to end up with a colostomy,
Right.
the bag, right?
Yep.
Because in the acute setting, when someone has to do surgery on you, on your bowels, they're not going to put it back together, because if they do, then they're going to leak, and that's bad. So in the acute setting, if you have a perforation, then they're going to go in, they're going to do what they can, and you're going to be stuck with a bag. Now, is it forever? Most of the time, no. But you'll, as opposed to if a surgery is done in an elective setting where, hey, Mark, you've had 5 attacks in 1 year, then we've just treated this. And once this calms down, let's take you in for an elective surgery so we could remove this disease part of your colon that just needs to go. We do it while things are calm. There's no infection. You're clean. They get in there, snip, snap, and then they put it back together. And then hopefully, you'll
Right.
be good. So surgery does come into play when there's recurrent attacks within the same year.
Excellent.
Yeah.
Well, Doctor, this has been a really fun conversation, only because of the compliments I've received on this today.
Yes, of course.
On the beard, of course.
Warranted. Legitimate, yes.
The fact that I can drink too. God, this has been the best.
Yes.
So no, I'm really glad you took time to come in here and talk about this, and you're welcome back anytime. Any subject you have, let's discuss. Okay.
Sure. I would love to be here. Thank you. This
Doctor,
was great.
yes, Dr. Issam Turk, gastroenterologist at Monument Health. Thank you for coming in, man.
My pleasure. Thank you for having me, Mark.